All right, Dr. Hurst, I will go ahead and bring up your case. Just give me one moment, please.
I did not upload it, so can I share my screen, please?
Oh yeah, I have your case, but do you want me just to share? Like I can give you the.
Oh, I have a PowerPoint of it. So,
Oh, okay.
yeah, so
That's completely fine. All right, I went ahead and gave you those capabilities.
okay, awesome. So, sorry, I have to allow my computer to let Zoom. All right, can everyone see that?
Yeah, it's perfect.
Okay, perfect. So this is a patient that is an 81-year-old male that I had been seeing from a different practitioner. Basically, he came in for long periods of time. He would notice pain to his foot. He would notice cramping, nighttime pain, burning sensation. He has blood sugars over 300, unsure of even his last A1C. The most recent A1C that I found of record of us was back in 14. He has recent stenting on his right side in 2022. No history of anything on his left side. So he was a gentleman that I kind of saw and I said, hey, we had a conversation like maybe we should start looking into some workup in regards to your vascular flow. So we ordered some ABIs at that time. These are his impressions from that. You can notice that the right side had a digital pressure of 89, digital pressure of 43 on the left, with an ABI even decreased to 0.62 bilaterally. And this was actually compared to his July 2022 ABIs. And so, we had a conversation. I was like, hey, you're certainly a little bit higher risk. Maybe we should start, certainly see you a little bit more often. Somewhere down that line, he reported to the emergency department, and he started to notice that to his left fifth toe, he started to notice some color changes. He noted a dark discoloration of his fifth toe. He states that it happened, a couple weeks, but it didn't resolve on his own. He did note some like streaking redness that I didn't appreciate, but I do have some clinical photos here as well. So this is how he presented to the emergency department, but certainly a dusky appearance to that fifth digit encompassing the entire thing. During that time, I actually kind of talked to him. I said, hey, we had some radiographs taken here in the emergency department that did show that he had a fracture of his fifth toe. And I said, hey, did you notice that you broke your fifth toe? Did you hit anything? He's like, oh yeah, I actually stubbed my toe on a coffee table. And ever since then, that's when it started to. So at that time I said, hey, like we really need to get you seen in vascular surgery. He wasn't certainly at any in terms of critical limb ischemia. He had a palpable popliteal pulse. Nothing. And I was like, okay, nothing in terms of I don't think you're going to be losing your leg anytime
Hey,
soon.
Dr. Hurst, can I
Yeah.
just slow you down for a moment? Because
Oh,
you're
yeah.
you're talking quickly, but I'm
Yeah, no
also
problem.
just looking at this picture and I need to know. So was this at Davis that he went to?
This was at Davis. Yes.
And this, I mean, I see this color and I'm like, I guess they're thinking ecchymosis, but I would love, oh, Kayla's here, hooray. You're our provider on this call. If you saw a color like this on a patient, would you think, okay, it's broken, or would you think there's something vascular happening? I also am curious because that fourth toe looks so white.
Mhm.
I would love to hear your thoughts, Kayla, just for a moment. If you saw this foot, is your first thought musculoskeletal or is your first thought vascular? 81-year-old, and just to tell you, there was maybe a history of bad diabetes and uh, some abnormal ABIs that were moderately abnormal.
I think I would go straight to vascular issue with that just because of the color of the fourth toe as well.
Right? That fourth toe is just that's
Yeah.
it. What about you, Dr. Hurst? Do you think, because you see so many more fractures and other feet things that don't come to me.
Oh, I immediately said he needs to see vascular surgery when I saw this. I think the point of this too was that, these are people that are I always almost think it's like walking, glass houses where it's like, hey, you have something like an injury like this, as simple as like a broken fifth toe, and it sets off a storm of inability to heal, dusky changes to 4 and 5. Like he had a little slight trauma to this area. It kind of goes in the fact that like sometimes you'll see people like 75-year-old patients with non-palpable pulses and they get this infected ingrown. And you're like, well, how the heck are you 75 and your first ever infected ingrown? But a lot of times you'll get vascular studies on those individuals. And if you find out that they have decreased toe pressures, low ABIs, and you're like, well, yeah, that makes sense. And I've even seen like firsthand where people will try and do an ingrown nail in terms of like a matrixectomy or something, very aggressive on these people, and then their toe ends up looking like this, dusky to about the level of like the MPJ, and you're like, well, that makes sense. Yeah, you kind of started
You should
that.
have checked a pulse before you did
Right.
it.
Yeah.
Okay, I'm just shocked this patient got sent home from the ER and then he's seeing you in clinic with this. That's
Oh, this is no, this
disconcerting.
I saw him here at the hospital with this.
Oh,
He was at the
okay.
hospital. So he ended up getting transferred to Mon General. And many months go by. So I thought, something probably happened. I probably lost track of him, like someone took care of him, like whatever. So he comes in then with this now. So he had seen the providers at Mon General. He underwent an angiogram, which all they said is that they did stenting. That's really like the depth of the op report. I have like the op report from the.
Is that Cindric that did it, or was it our other guy,
That was the other guy.
Mo?
Mm-hmm.
Because I have like both of their contact infos now. Like
Yeah.
Cindric literally just texted me before I got on here to ask about a patient.
Yeah.
I wonder if we should bring him in on this stuff.
Yeah. So this is something, like he didn't do anything in terms of bypass. It was certainly something in regards to like angio with intervention in regards to that, whether it be ballooning, stenting. I'm unsure of that. But certainly when I saw him here, like the foot was a lot more warm. It was more profuse. Like I was like, oh, there's a clear difference in regards to this. Unfortunately, when they went and amputated the toes, this is like how he presented. He states that he followed up with the person who performed the amputations and they took out his sutures and like, all right, we'll see you never. Like that's basically what he told me. How much of that is true, I'm not sure. But this is how he presented. So I removed all this and then we were kind of left with this in the remainder of the ulceration.
And can you talk to us, like just describe what you're seeing here to
Yeah, so
clinic staff?
Yeah. So, in terms of this, at this, he had like a boggy eschar to this area of the ulceration. At that point, once removing all that, he had like an ulceration that was full thickness in nature. It had fibrotic material. There was no purulence. There was no exposed bone medially, but you could see even laterally there's some like cartilage of the fifth metatarsal kind of poking out right there. So certainly some exposed bone to that area.
Is there the fourth toe though? Isn't that like the bone right there?
They took the fourth and the fifth toe, but yeah, certainly the fifth toe, and then it's slightly covered, but yeah, but not like
that's the bone.
Yeah. Mm-hmm.
Okay, and that's I think one point right is you have to uncover the wound.
Yeah.
To see the depth of the wound, in case the providers on the call just need to know that, because I think patients come to them and say, oh, it was just this small and now it's huge. It's because that was always there, but he had to uncover it to see what was going on.
So this is now, and like to your point, like we started doing like Dakin's wet to dry because I was like, hey, we need to like reset this. There's some literature that shows that like now Dakin's, it can be used more and more for like our infected diabetic foot ulcers. But now you can clearly see there's certainly fourth metatarsal head exposed. The fifth metatarsal is over there under that fibrotic material laterally to the area, but certainly a more granular appearance in the ulceration around that area of the bone. The problem becomes is that when you have this bone exposed, like it's very difficult to granulate over. So at this point I was like, hey, maybe we could do a wound vac or get you set up in terms of like something we can granulate over this tissue. But then I set him up with home health care and he said, I can ambulate and get around in my house. So then he was denied home health care. So one of those things where he's like, they came and interviewed him and they're like, oh, do you have like XYZ? And he's like, no, I don't have that problem. I can get around and I can go out and about. And you're like, well, you're not homebound, so you're not approved for home health care. So we continued with the dressings after that. And because of that metatarsal that was exposed at this point, I was like, without being able to do the wound vac, I was like, well, I'll just remove it. So in the office, I took a rongeur and I went proximal to the area of the metatarsal, and I resected the metatarsals 4 and 5, and I sent it off for culture. And it ended up growing MRSA and then alpha streptococcus species. And I sent that for as well for like more MIC in terms of like what antibiotics would cover it. And I had a lengthy conversation with him in regards to like, hey, do we do IV antibiotics versus oral antibiotics for like long-term treatment? You know, we talked about in terms of studies, we talked about the Oviva trial in Europe, the oral versus IV antibiotics, about how there really is no difference. But I talked to him on the pros and cons, especially as someone who has poor vascular flow to that area to begin with. So he elected for oral antibiotics. So we did a 6 weeks course, and I apologize, I don't have the actual antibiotics we did end up getting him on. And I was like, oh, also maybe we should repeat those ABIs. So, you know, this is his repeated ABI after several months of dealing with this ulceration. So the left side, the ABI is a little bit increased compared to previously, but the toe pressure is still limited in regards to that. With being 46 millimeters mercury. So I was like, well, hey, you know, if we ever stagnate, we maybe need to get you re-seen by someone in terms of vascular. But then all of a sudden, after treating that, in terms of the 6 weeks of oral, this has ended up with the ulceration we ended up with. And I was like, man, this looks beautiful. You know, it's larger, but like, you know, I had to kind of go a little bit farther back to like resect that in the office. I'm like, this is like a granular wound. There's no exposed bone. It's to the surface, you know, it's in terms of depth. So I was like, let's do a skin graft. You know, the last thing I want to do is harvest a skin graft, even though a lot of the times like autografts can be better in terms of like take in regards to the foot. But I was like, let's try just a split thickness skin graft. And we, you know, we did something in terms of like an allograft, like a Theraskin we did for him. So after one application of Theraskin, this is what it ended up looking like after the application of Theraskin. So a huge improvement in regards to that ulcer in terms of size, really just kind of dealing with the area where the fourth was. And then, so we started with just some like collagen, and this is with him the other day, just like some, you know, areas of like hyperkeratosis that are forming, a small area open proximally. And then this is him 3 weeks ago now. The whole area is healed, no areas open. That place proximally is just some silver nitrate that I use to cauterize the pinpoint bleeding. And then we set him up, and we're going to get him some diabetic shoes and inserts coming up now. So just like a kind of combination case of
That's a great case.
of like vascular and infection. And then like once you kind of manage all those things, all of a sudden these wounds get better. Now, he is certainly someone that ended up with a minor amputation, but it certainly could have been gotten a lot worse for him, you know, if he wasn't being seen routinely in that regard. But if there's any questions, like, be, you know, like maybe if I had to look back on it, are there some other things I would have done? Maybe gotten him in quicker to see, you know, I put a referral out for vascular surgery, like, you know, before he had a problem. Now, would something been done? Probably not. Maybe like a
No.
walking program or some sort of like medication management, but certainly he would have been established, so it could have been a little easier too, like once you get into problems too. So that's probably what I would have done differently with him, is like, hey, maybe I would have been a little bit more pushy to have him see someone, even though they, you know, intervention probably wouldn't have been done then, but at least he would have been established.
So sorry, I agree. Vascular, it would just be more about getting care established. And then I could also, you know, I probably would have been like, hey, if you have any wound and it doesn't heal within 2 weeks and blah, 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 you need to come see us. And then, yeah, it would be an easier pipeline to pop them up to Morgantown for a procedure when, you know, the wound arose. The other thing is clearly communication for follow-up for this gentleman from Mon. That's really unacceptable that that they didn't get a podiatrist kind of put on there, because Dr. Finling is a podiatrist that takes care of Mon patients. So he should have been following up, and perhaps he was supposed to, and I don't know what happened, but this seems like a patient Dr. Finling should have been following, right, you know, and since he's in your area, like that's, I don't know. I think for us, we would have had podiatry working on the patient as well, and maybe even and probably establish follow-up at Davis with our wound care colleague down there, because we have someone from Buchanan that's going to Davis now to, you know, cover for Josette until that happens. So, or I mean, because I know you, I would have probably been like, all right, our podiatrist up here is going to do this, and then we're going to connect you guys so that you don't show up with a wound with the, you know, toes. sticking out, like the bone sticking out, because that's just not going to heal. And I think the antibiotic question is great. And unfortunately, Dr. Noriel is not on the call since she's our infectious disease doctor, because it would have been great to have her input as well. And then the other part is the endocrinologist,
Mhm.
because if that's so, what is happening for that?
Yeah, he's getting that's the problem too, is that we don't have a lot of in terms of like endocrinology, a lot of primary care are managing. And I think like also like he didn't even know what insulin he was supposed to be. It was a whole thing too in that regard. So I think like, I'm seeing him in like a couple weeks now where we're gonna get that all reestablished. But I think he just recently started like a new regimen in regards to his insulin because he like wasn't it was something silly, like he mixed it up like in terms of like taking it nighttime versus like all meals. So his like sugar has always been high, but it's actually been well controlled in like this interim too. So it's like, that 3 phase of, wound healing, infection management, blood flow management, endocrinology, like kind of all came together for this patient, certainly.
It's a great case. Thank you so much for presenting
Yeah.
it. Does anyone else have any other comments, or should we pivot to Dr. Diamond?
All right, well, I think we did the echo pause there. I really appreciate that, Dr. Hurst. Very great case, and thank you for presenting that today. All right, I can go ahead and share the screen for you, Dr. Diamond. Give me one moment.
All right. Can everybody hear me? Okay. All right. Elizabeth, do I need to do anything to, okay. You go.
No, you just let me know next slide when you're ready to go forward, and I will go ahead and do so for you.
Okay. All right. Well, thanks everyone for putting up with listening to my presentation today. So I wanted to kind of make this a little practical. My background is family medicine, and did practice rurally, remotely, maybe not as rural as where you guys are coming from, but not a lot of access to specialty services, certainly in the county that I lived in. So I tried to approach this topic this way. And I think when we look at how we handle chronic wounds when they come into our office, chronic wounds are different than acute wounds, and the physiology is different. So some basic wound concepts that I like to preach and teaching in the center when residents and med students come through is a couple things. Wound bed preparation. So when we first see, this is what we're looking at the wound. We got to kind of start at the bottom and work outward. So wound bed preparation is, what does that wound bed look like? And if we think about the wound that visually, like Dr. Hurst just saw with the boggy eschar and the fibrin, or is it a fully granulated wound like he had later on? So you want to see what you have first. Do you have and put it into 2 categories. Is it a wound that needs cleaned up, or is it a wound that's now ready to be rebuilt? So in terms of wound bed preparation, we do a few things. Santal and Metahoney are 2 ointments that are used to clean the wound bed up of non-viable tissue, and then sharp debridement. Sharp debridement does a number of things. One, obviously, is to remove the non-viable tissue, prepping the wound bed for further management. It also disrupts the biofilm, the slimy surface of the wound where cells communicate in wound healing. It also refreshes edges of wound, which is the healing front. So all these things with sharp debridement help a chronic wound think that it's a new wound and allow and promote wound healing. After that, we want to look at absorption. How much do the wound, whatever wound we're looking at, how much drainage is coming out of it? And then what dressings do we need to handle the amount of drainage? You can go to the next screen. So this is just some basic concepts. Let me move the people here. These are just some of the things that that I think about when we're looking at a wound. Is what type of wound is it? And these are just the different categories. And then I put here just some very common in the wound care center diagnostic testing that are our most common things that we are probably ordering. Do I order this on every single individual every time, you know, on new presentation? No. But x-rays to rule out osteomyelitis, pulse volume recordings to assess their vasculature, venous insufficiency for venous leg wound cultures, labs, and then more in-depth diagnostic studies for osteo. Next slide, please. Okay, so we talk about wound bed preparation. I wanted to mention this. This is something that does not require a prescription. It's called MediHoney. This is provides a moist wound bed and promotes wound healing. The other big thing that this does for wound healing is that it keeps the wound bed at an adequate pH for wound healing. Wounds, if they are too wet or too dry, do not heal. So if it's a desert-like wound or a swamp-like wound, they won't heal, and that's because the pH is thrown off too. MediHoney also provides antibacterial coverage, particularly this brand of MediHoney. This can be ordered on Amazon. I know not everybody has internet access, but we do have some patients that will actually order it. We keep some in our clinic, and we'll hand out. Some patients, if they're coming from the hospital here, may be coming home with that as well, because I believe the hospital sends home their tubes as well. So if you've had any inpatients, but that's always a nice ointment to go to, is something that you can offer your patients in clinic. As a family doc, I did try ordering this a few times. Some insurances, it did go through. I think it's just a trial and error that you would have to see. If we could do next slide. This other ointment is Santal. Santal provides enzymatic debridement, i.e. it'll eat away the bad tissue. It also recruits chemically, it will recruit fibroblasts, endothelial cells, keratinocytes through migration and proliferation. It has some pain-reducing properties as well. I advise patients of that. I tell them it's not necessarily going to take all their pain away, but sometimes it can certainly provide some local diminishment of pain. And I really wanted to stress this, it does not harm any healthy skin. We have to do a lot of re-education for our patients here. Many home health nurses on the floor, you know, kind of send that message, and some patients are afraid to use it because they're afraid it's going to eat away their good skin. We use this all the time in very large quantities for very large wounds, and you're not going to have an issue with that. Thing to note is that it is deactivated by silver dressing, so it's not going to be as, excuse me, not going to be as potent, and you're going to not be as effective. Next slide. So this, I wanted to just show here a wound for a couple points. We want to look at the assessment. So I talked about the wound bed preparation. And a point I wanted to make here, because I see this from the ERs, the urgent cares, and sometimes coming in from primary care, this is not pus. So what you're seeing, this is adherent yellow tissue, which is fibrin and slough. Okay, it's non-viable tissue that needs to be removed from the wound for effective wound healing to occur. But many times I've seen patients get admitted to the hospital with this presentation because someone thinks it's infected. If you note the peri wound, which is also important in wound assessment, you can see how white it is. That's maceration. So that's a clue right now that that wound is a heavy draining wound, and you need to get a hold of absorptive dressings and get management on that, or you're going to have further skin breakdown. So I just put a typical plan in here to kind of show you what we would typically do and recommend in our wound care center for something like this. Cleansing the wound. Wounds are not sterile, so soap and water is fine. You can use wound cleanser, saline, pat it dry. Then I would go with one of our 2 topical wound bed prep agents in this situation. We do not have full granulation. That means when that wound is not fully red or pink with good tissue, we need to use one of these ointments and sharp debridement. Now in the primary care center, we're probably not getting into all the debridement, but these are things that you could start to do or put on the patient while you're awaiting getting them to specialty care. Santal or Meta-Honey should be applied in a nickel thick layer. That allows it to function more efficiently. Then I would cover this wound with absorptive dressings and have them change it daily. There's no real reason to change it more frequently unless you just don't have the right absorbent dressings. One, insurance will cover dressings for daily changes. And two, you want to give time for the Meta-Honey and Santal to be effective. Next slide. So here I included something that may be very helpful in your practices. So that's why I wanted you guys to be able to have access to maybe a hard copy. These are some links. So Santal is, if you often are dosing Santal, it can be dosed based on the wound size. Many times I eyeball it and kind of have an idea on smaller wounds whether how many grams a patient may need. Typically, your tube sizes, kind of like steroid ointment, come in 15, 30 gram, 60 gram, and 90 gram. However, on your larger size wounds, this dosing calculator is helpful because when you send a prescription into the pharmacy for Santal, if you include the length and the width and say 30-day supply, the pharmacist will then calculate out a volume rather than giving your patient a small tube, charging them a month's copay, if that makes sense. So that just is a little calculator to help you determine what size tube your provider should send in. This next link is very helpful. So for West Virginia Medicaid patients only, and if they have Medicare with a Medicaid secondary, this won't work. If they have Medicare at all, but your basic non-Medicare Medicaid patients, Smith & Nephew has a patient, that makes Santal, has a patient assistance program. I cannot begin to tell you how much free Santal we've been able to obtain for our patients. They will mail it directly to their home, which would be another very helpful thing in your practices and for your patients down there from what I've heard. There's a form, so if you go to that link, we printed off an online form, made a bunch of copies, and they can even get you set up where your provider's information is already on the pre-printed form. But I've had some patients get $10,000 worth of Santal a month for free. So this may be something that is really, I think, a one key point, being able to have access to that. And if you have a staff member that can, you know, put the basic information in and fax it off. And so I really wanted to give you this help. We've had a lot of patients help with this. And some of your commercial plans may pay for it, but this, unfortunately, is only for the West Virginia Medicaid patient. And it will, like I said, that will come through the Smith & Nephew program. So those are a couple links that may be helpful to you that you want to save. Next slide. I want to talk about, we talk about the wounds and the dressing. So it can get very cumbersome trying to memorize all of these things, but I want to talk about basic concepts. After you have your wound bed prep, so we've talked about the ointments and the agreement, then we talk about building these dressings. A non-adherent layer are basically dressings that are used for patient comfort. That's their role. They allow the dressing, not whatever dressing you're going to put on, this will allow it not to stick. So it's helpful to use next, after your base layer, on fragile skin, so your elderly skin that might tear. If you are concerned that dressings are very painful and dressing changes are painful, these are helpful to kind of throw that in before your absorbent layer. Some common names are Adaptic, Theraform, Cuticerin, oil emulsion dressing, and Vaseline gauze. Any of them are fine. That's basically their function. When you feel you don't need it for a patient, it doesn't need to be in there. Next slide. And these are just some pictures. I mean, some of these everybody's seen and I know, but I just wanted to, sometimes having a visual along with a name can be helpful. So next slide. Then after we have our wound bed prep layer, we've got whether we need a patient comfort layer that's on here, we talk about absorbent dressings. Think about these in two categories, moderate drainage and heavy drainage. And a lot of this, some of these advanced dressings, To get these covered, we'll talk about it later, and I'll show you some ways. You got to go through a DME company. But if you have patients hooked up with home health, you can kind of just tell them what you want, and they will acquire these dressings. But lingo is key in your documentation. To get absorbent dressings covered, you've got to say somewhere in your note that you have moderate or heavy drainage. Moderate drainage is going to be in a category of what we call calcium alginates. There's silver, which provides a little bit of antimicrobial, and non-silver versions. I will tell you personally, I can't tell you last time I used a silver product. It's not a bad product. It really kind of came out with used to kind of be used for a few weeks to kind of get a wound bed prepped and then transition to something else. But sometimes silver dressings, when used prolonged, cause a lot of pain, localized skin rash. Often we use a lot of Santal, and so it deactivates. So, and a lot of chronic wounds aren't infected. So a lot of our wounds, they're not healing because they're not healing because they're infected. So that's just personally why we don't use a lot of silver dressings, but it is an option. And these are just some names of heavier dressings for heavier drainage. Zetavit, I will tell you, all of these, with the exception of Draw-Tex, work kind of like a super maxi pad by locking the drainage away. Therefore, the wet drainage is not on the patient's skin. So like an ABD pad that gets wet, it's now is a little bit better than gauze, but and like I said, some of these concepts are a little bit more advanced for what you're going to be doing, but I think just being aware of what they are and how much you want to kind of get into some of this. Next slide. On this slide, I just wanted to put just a few helpful wound tips. If you have a wound that is extremely exudative, no matter what the wound bed looks like, my initial plan is to control that drainage first. And the reason is, if you have a heavy draining venous leg wound, lymphedema, it doesn't matter if you need Santal or Metahoney or it's clean enough for collagen. If it's draining too much, everything is going to be wasted. It's going to float off. So the point I wanted to make is handle one thing at a time and build from that. You don't have to fix everything from the beginning, and don't be afraid by large wounds. Control your drainage first and then move on. Another tip is when using calcium alginate for, say, deep wounds, a pressure ulcer that's deep, a groin wound that is deeper in a tunnel, you can take a square piece of alginate, cut it in a spiral way to form a rope. Okay, this will allow you to loosely fill any deep wounds, and that will start your absorption, and then you want to cover that wound with something even more absorptive after that. But it allows you to kind of not pack so tightly, but also start to help control that drainage. The next one is a very, very helpful tip. Crushing a flagyl tablet will neutralize any odor in your wound. It can be mixed with Metahoney, it can be mixed with Santal, it can be thrown in there under wound vacs, it is not going to hurt anything. It is purely there as a deodorizer. It makes a world of difference. This can be a very social negative, the malodor of wounds to patients. So and it's cheap. Every insurance covers it. So I wanted to just throw that tip in for you.
That's awesome. I've never heard of that before. Just FYI.
Yeah.
That's
Even
awesome.
our pharmacists here have argued, I've had to fight for it, but it is, there are articles in the wound literature about it. It's simple, it's easy, and it makes a huge difference, believe me. And again, if a wound stops smelling, it can be stopped at any time. I have some patients that, hey, I need it 3 times a week. I use it 3 times a week. Again, it's almost a patient comfort type of thing. Consider an x-ray when evaluating new wounds over bony prominences. This is to rule out osteo. So particularly your foot wounds, you got it over a metatarsal head, a toe, heel, a malleolus. I always make a point of x-raying. Even if I'm low suspicion, I kind of do it routinely to rule that out. So just another tip to keep in the back of your mind when you're looking at a new wound. And again, for new lower extremity wounds and foot wounds, I can't stress it enough, think about ordering PVRs or vascular studies earlier rather than later. Even if I feel pulses, if they're a smoker and a diabetic, they're going to get them. They're just going to get them. Remember, diabetics can have non-compressible vessels, so You may be feeling your pulse, you may be not feeling great pulse. So that's just what we teach in the algorithms that we use. Next slide. Check my time here, try to go fast. Couple wound myths that I just wanted to kind of debunk. We talked about this one. Santo will not harm or eat the intact skin. Only keep wounds open to air when they're healed. Often we'll get this a lot of times. Open wounds when exposed to air or increase your risk of infection, and it's just drying out the wound. Many patients come in saying, well, it's a scab. It's not really a scab, because a chronic wound will not heal with a scab. Scab is the result of the end of the acute wound healing process. So what you're seeing is just a desiccated wound bed. And remember, wounds need to communicate through that biofilm. If you don't have a warm, moist wound bed, that wound can't communicate. So the endothelial cell migration, the proliferation of your fibroblasts, your collagens, they need to be able to communicate across that wound to promote healing. And then the other one is compression and use of lymphedema pumps. This is another one we get a lot, even sometimes from our lymphedema therapists, is that they can't use the compression if they have wounds. That is not true. You need the compression as part of the wound healing, and then obviously after healing for prevention. So there's nothing that is going to be compromised by using your lymphedema pumps or compression if you have open wounds. I mean, obviously you want to have them covered, but next slide. Okay, these are just some tips on documentation requirements, particularly if you guys want to try to set up a way to order your patients some dressing. So I wanted to throw a slide in here. You need to get any kind of absorbent dressing through DME companies, your note needs to somewhere in there say that the wound has moderate drainage, at least moderate. You can say heavy, but at minimum, you need to document moderate drainage. You need to document that the wound is full thickness. Okay, that means it's down through the granular. You know, you don't have a partial thickness wound. You won't get any absorbent or dressings covered if a wound is not full thickness. You need wound dimensions somewhere in your note. And then if you do get into the debridement types, mechanical, this is just brisk cleansing. So, you know, even if I don't do any sharp debridement, our nurses are cleaning this wound briskly with gauze. You know, every patient gets a mechanical debridement because that stimulates the wound. So, you know, even when patients aren't in the clinic, when they're changing their wound every day, I have them do this if they can tolerate it because it is disrupting that biofilm. The enzymatic debridement is the using of Santal, so you can put in your note that you've done an enzymatic debridement if you're using Santal, and then anything that you use that's sharp would be considered sharp debridement. Next slide. And this is just my basic sort of silly takeaway, but if you think about dressing a wound like building a sandwich, every layer has a purpose. You start at the bottom of you want to cleanse the wound. Then we talked about the wound bed preparation. Does it need cleaned up? Do you need your ointments, Santal, Meta-Honey, debridement, or is it granular? We kind of go to collagen, which I didn't kind of get into in this lecture, but like again I said, do you need a non-stick layer because the patient's in pain or has frail skin? What kind of drainage control do you need? Is it a type of wound that needs compression? Venous leg ulcers, yeah. Is it a type of wound that needs proper foot offloading? Your diabetic, your neuropathic wounds, all those kind of things. So this is just a simply practical way of slowing, you know, kind of slowing down your mind into thinking how we can help this wound. Next slide. So I just threw a couple slides in here where I just put what assessment things I'm looking at and what I would do as a plan, if this is at all helpful. So this is assessment. I would tell you this is a picture of an arterial ulcer. So what I wanted to point here is all redness is not cellulitis. So a lot of patients are admitted to the hospital here for cellulitis. I know since we started our clinic here, we've been able to help reduce the recurrence admission rate because of cellulitis, just for getting patients in a wound clinic. But this is rubor. I know pictures are kind of hard to tell, but this is rubor and not cellulitis. The arterial ulcers are usually your punched out, is the classic description. And a lot of times these are in common locations, so it's important. So when we look at this, we have a punched out ulcer in common locations. You'll see them on the lateral first med head, fifth med head, heels, and the malleolar regions. You want to check for diminished pulses, look for hair growth. These are all physical findings and assessments that might lead you to an arterial ulcer. So in this wound, if I saw this, and what I could do if this was in my primary care clinic, while I'm getting a workup, referring them to vascular, I would recommend Santal or Metahoney to sort of this area that's fibrotic and eschar. In my clinic, I would debride it, probably we would debride it, allow that wound to start draining and release this sort of hard cap, because there's a wound under there, and if that drainage can't go out, it's only going to bore deeper. So we're going to want to treat it, put some absorbent dressings on, but that's how I would approach that. And those were sort of the points I wanted to make. Location, the appearance of the ulcers, and the ruber and the physical exam signs of an arterial ulcer. Next slide. Again, here's just another one you can see here. So some of these will, like in Dr. Hurst's toe, you had the dark toe and then the pale toe beside. So here you can kind of see the ruber, but you see this, this is another arterial ulcer. And the punched out lesions, lack of hair growth. And this here is not pus. Again, it's fibrin. And we would want to, and you're going to see a lot of that in arterial ulcers. A lot of them aren't going to clean up right away until the blood flow is back. Once this patient gets revascularized, it's very often pretty quick that these will clean up with debridement and Santal. But in the meantime, while we're waiting for this person to get into vascular, okay, they still have these wounds. They're still draining, and we don't want them to go backwards. So we want to still treat them, knowing that they might not change a whole lot until the revascularization happens. So the same kind of thing here. Here, the calcium alginate, which almost looks like felt, can be cut in that row form, and you can sort of snake it between the toes to help provide absorption as well. Next slide. Here's a common place for diabetic foot ulcer. Again, pulse assessment. We feel every wound. You always want to palpate for bone exposure. While you can't see it, you may be able to feel it. You want to look for maceration. Here we can see it around here a little bit. This is kind of wet callus. We know if there's callus there, the patient's not offloading enough. So you want to think about and check their footwear. What are they wearing? How I would treat this wound, this is a little bit different. We see a nice red, pink, not what we call granulation tissue. This is ready to be rebuilt. We would put collagen in here initially. There's lots of options here, and some of it is determined based on the patient and how they respond to treatment. In the wound clinic, our first choice would be to do collagen, and if they're responding to that, we would debride this wound, use collagen and a super absorber, and get them in an offloading shoe. If they're responding, we keep them on that trajectory. When they stall, we can go to other things. If a patient has good balance, one of the first things we offer the patient is kind of a gold standard, is a total contact cast. That's something we would offer in our advanced clinic, but this suspends the patient's weight at their ankle. It's a weekly cast that we apply and take off and treat their wound. So there's lots of options here, but I just wanted you to note the metatarsal heads. When you see that, think of your neuropathic ulcers, and not all, you may have a patient with idiopathic neuropathy is going to present the same way as a diabetic. So the testing that we would usually do on initial assessment, I kind of put at the bottom. Because this is over bonehead, it doesn't look and appear like it's got osteomyelitis, but I would rule it out. Next slide. Okay, this is a heel and this is a pressure ulcer. Again, this is not pus, this is fibrin. Some of the same types of assessment is what I would do for this one as well. And I put here check footwear. If you have these heel ulcers, even with a pressure ulcer, you know, if it's a non-ambulatory patient, you want to get them in some kind of offloading heel boot. So that's still important. There are footwear for the heels as well if patients have decent balance. So now here, I put collagen daily if this was cleaned up. I think I switched my pictures around. Sorry about that. But if it looked like this, I would honestly go with Santal over Metahoney when you have this thicker tissue. Metahoney is going to take a lot longer. But sometimes Santal is cost prohibitive, and in those patients, we would think about Metahoney.
I would
But
like
again,
take
some
an
of-
11 blade to that personally and just try to take it all.
Well,
off.
yeah, well, I'm just saying in a family practice office, that might not be practical. So yes, in the wound care clinic, we're going to always debride this. But in your clinic, if you saw this and you're like, shoot, we got to get them to podiatry or wound care, you could start them on Santal and get this wound dressed so that that's softening that tissue and preparing that wound bed for debridement. If it's something you want to get into and do, and you have time in your primary care offices, you know, I can help you with that. We can talk about that and give you the documentation requirements to do so. Probably another time. But there's still things. What I wanted to point out is there's still things that you can do as a PCP, like get them on the Santal, or if they have Medicaid, to get that cleaned up. It may take longer than getting a surgical debridement right away, but if you have a patient that just won't go, that's at least a tool you can use in the meantime to get that cleaned up, or until they can get to specialty care. Next
Well,
slide.
Dr. Diamond, I just want to point out that that's something I learned from you. Is because when I didn't have time in clinic and I'm so busy, like when I'm down at the rural clinic, starting them on Santal for a week so that it's less
Okay.
adherent, and then I bring them back, and then it's like so much easier to take off. I did kind of learn that as a trick that you had taught us in vascular clinic.
Exactly. I mean, certainly surgical intervention is going to get it off quicker, but it's not always the most feasible. It's not always what you can do, but that's what the Santal does, is prep that wound bed. This is a venous ulcer. Okay, this is probably more of an inflammatory venous ulcer, but I want to show you that you can see in this picture how wet it is, how macerated. This is a wound that you may see with lymphedema, really bad chronic venous insufficiency, IV drug use, where their veins are shot. But if it's really heavy draining, this is the type of wound, the first thing I would do is control my drainage. And I would use a non-adherent layer because these are often painful. Once you get this drainage under control, you can then attack this wound, which is pretty nicely granular. But this was my point here, is compression, non-adherent layers, and really control your absorption. Now, I also mentioned here, I personally, Una boots are a treatment for venous ulcers. I see from some other clinics, they just kind of arbitrarily across the board, Una boots for everything on the leg that's a venous ulcer. But heavy draining wounds really should not be put in Una boots because you're trapping and you're making everything more wet. You want this changed every day. Una boots, you're not changing every day. So when you have heavy draining wounds, it's better to get that off or you're going to risk infection. Next slide. So this is really the end of what I had. The next few slides, these are for the providers down there. These are a couple wound DME order forms from a couple companies that we are using. And the reason why I wanted to start with this First Medical, and you can feel free to email me, chat me, however, if this is something that might be beneficial. This company is all online. My nurses love it. You can track the orders. You can put it in online. They make it pretty easy. They text or call the patient. If the patients have access to all that, they can track it on their phones, just like FedEx package. But for your staff, it makes it easier for reordering because you can just click everything online. They can do an in-service with your staff if that's something. We found them very easy to work with. So this is just a typical order form. And like I said, I just wanted you to know that they exist. If there's something that you think would benefit your clinic, I'd be more than happy to, set up a time after to help you with that, to more specifically help you customize something that may be beneficial. But even if it's something like we'd like to get some dressings for our patients, even to hold them over to getting them to podiatry, vascular, or wound center, this is a good company that we have found. And they also will do compression, you can see at the bottom too. Next slide. And then this is another real important one, Adapt Health. And the reason I mention this, West Virginia Medicaid typically will pay for nothing. So it's very difficult to get these patients something until we found, I don't know how this company is doing it, but Adapt Health, we are able to get some of those Zetavit super absorbent dressings, which can be very, very critical for the Medicaid population. So I wanted to really point this out to you guys. And this is billed through their insurance. So you're not sending, this is not going to be sent to a regular pharmacy. These are DME supply companies that will provide dressings. And again, my staff or I can probably help you if it's something that you guys sit around and talk about. But you basically fill this out, circle what you want. You'll have to provide certain documentation things that I said before. And like I said, we can go over that another time if you would find it helpful. But Adapt Health, if we have any West Virginia Medicaid patients, the only company we've been able to get any kind of absorbent dressings for, which is important. Next, I think we have one more slide maybe. This is just an example of that SANTL form that I was telling you to get free SANTL for your West Virginia Medicaid patients. So I wanted you to be able to, like I said, and we can get, this is just what it looks like. So again, this has been a game changer really for our Medicaid patients. Being able to get them something absorbent and SANTL has made a world of difference. So those are just a couple things that I thought might be helpful to you guys, or knowing how to get them the ointment, how to get it for free, particularly if transportation and access to care is limited. Some dressings and some SANTL can go a long way. And I think that's it. Oh, I just want to put, this is just slide that there's 3 of us that provide care in our clinic. And these are our locations, and any of us would be more than happy to help you in any need. I know some of the family docs have reached out to me through chats when they're doing home visits or something. We're here to help you if we can. So never feel afraid to reach out. Thank you.
Thank you so much. Isn't Josette also at Fairmont?
I think, but I'm not sure what she's exactly doing.
They
The
set her
last
up for
time I
wound
talked-
care at the Gateway Center.
I don't know who they is. I don't know.
Like HVI, Ashley
The
Jackson.
HBI is sending us to Fairmont so we're training a nurse right now. So Haley Nicholson mainly will go there. I may be there to start a few times a month to help get it running. So, I mean, I'm not sure about Josette specifically.
Interesting. I know we were hoping to bring Josette to the Davis clinic, like the Elkins
I mean, that's
clinic.
last time I talked to her is I talked with Jen and her to see what her availability might be if the HBI decided to do vascular wound thing. But I thought it was more for down near Davis, actually, in Elkins.
I think
When
that's
they talked to me about it.
the like later plan, but in the meantime, she's at Fairmont.
Yeah, this Fairmont
Maybe I'll
clinic will
reconnect you
be
guys.
will be our office. It won't be with Giuseppe. I mean, this Fairmont clinic is my clinic with my APP. This is not whatever the Josette's doing is something different.
Okay, well, I know it's like HVI, so maybe we'll connect you guys to make sure that they're not duplicating or like figure out what's going on.
Yeah, Ashley Jackson has been involved from this has been a 2-year project with Fairmont, so I thought Gateway was under ambulatory care, not HVI clinic was at Fairmont, but whatever.
Okay, that's helpful. All right. So does anyone have questions for Dr. Diamond? Is Kayla, did she already have to take off? Because I know we had waited for her to come on. Oh, no, you're right there. Hooray. We waited for you to come on since you're the only provider that was available today. And I'm
I
hoping,
appreciate it.
yeah, no, I'm hoping you'll tell Kristen that she can watch the recording
Yeah.
if this is helpful.
Yeah, I think that this was very helpful today.
Yeah, and I'm hoping, Tina, that you can also tell I know Dr. Rubiker's already worked with Dr. Diamond, but I'm hoping that Jennifer and I bet Brittany would probably pick up a lot too. I'm hoping they'll watch this. Does anyone have questions for Dr. It's pathetic.
Yours.
Anyway.
Thank you. Feel better, please. Oh my gosh.
Good. Anyone have questions for Dr. Diamond? I'm willing to stay on a little bit more. Can we do that on the Echo platform? Are you guys okay with that so that we can ask your questions?
Of course, yeah. If you guys want to ask any questions, I'm happy to keep it going for a little bit longer. I only have one announcement. Dr. Hurst will be doing a presentation on December 19th on diabetic foot ulcers. So we'll look forward to that, Dr. Hurst. But yeah, we're fine sitting here waiting.
Yeah, so if you have Kayla, do you have a question about like any wounds that you're taking care of right now?
Fortunately, I don't have any wounds right now.
But maybe let's talk about the venous wounds. Because I think one of the biggest things I get sent to me is, again, you guys sometimes call it PVD because everyone thinks that the V stands for venous, but no, it's just vascular.
Mhm.
That, we get these big swollen legs that really just, and that are so wet,
Mhm.
that really just need to be handled. The drainage and the compression are so important.
Yeah,
Um,
I had seen the guy that Kristen did the presentation on a couple
Yeah.
weeks ago. I had seen him before that as well. So just with him, I think it's compliance for sure. But
Has he shown up again?
nope,
Oh,
nope, not since you've seen him.
right. Oh, I did want to make an announcement. So they are doing ABIs now and PVRs at PMH.
Yes. Mhm.
They got a machine, and I talked to the tech, so that's great.
Mhm.
So please start sending patients there, if they qualify, if they screen as high risk for vascular disease. So anyone with diabetes that's over like 50, I think, is the cutoff. And I can send you a list of who you might want to screen.
Yeah.
But if you examine them and they have risk factors and you can't feel pulses, then definitely send patients that way.
Okay.
Anyone else? Any other like wound stories that you want to tell or anything else? Because I think it's a great talk. And I think the Santal stuff is so important, because that is something that you can do.